All right, welcome back to another serving of PT Meal podcast. In today's episode, we are going to talk about a recent article that was published online about the demonization of manual therapy. It was written by Chad Cook, a professor from Duke University. So, to help us with the topic is um, Ulysses Juntilla, physical therapist, doctor of physical therapy. He is a board certified clinical specialist in orthopedic physical therapy. He is specializing in osteopathic physical therapy and also certified in spinal manipulative therapy from the American Academy of Manipulative Therapy. He is also a fellow of the American Academy of Orthopedic Physical Manual Therapist. Am I correct? Or
Yes.
manual physical therapist?
Uh,
The resident He's also the residency director of the Orthopedic Physical Therapy Residency Program in Columbia VA Healthcare System and the founding president of the Philippine Academy of Orthopedic Manual Physical
I,
Therapist. I was typing this when I was sleepy, so I think I got some words wrong. But welcome to the show. Oh, Yul.
no problem. Yes, thank you so much,
Yes, Johan.
Johan, for inviting me, and it's a great opportunity to share my views as well.
I would love to hear your thoughts about it. But before we start, could you give us your physical therapy story, how you become a physical therapist, and what do you do now?
Yeah, so I actually hailed from Leyte. Originally, my parents from there in the Philippines, and I did my PT school in Cebu. I was class or batch 2000 back then, and then I came to the US in 2006. Prior to coming, I was teaching there in a local university. I was doing anatomy and physiology, the gross anatomy laboratory. And then when I came as a traveler therapist until I landed a job at the Veterans Hospital locally. Until then, since then, it's my 14th year of service.
Wow, wow, that's one of my dreams to work in VA, but no, it's still a dream. So going to our main topic, which is the article of Chad Cook, demonization of manual therapy. What was your initial reaction to it? And talk to us about why. About your Facebook post that I read that instead of demonizing manual physical therapy, manual therapy is something that is abused and misused. So yeah.
Yeah, so I was definitely reviewing Chad Cook. Chad Cook is a very uh, popular author as well as professor, and he's also a fellow of OMPT.
Mhm.
And when I was reading the article, I was actually amazed that he used the word demonization. But when you
Mhm.
look farther, I'm actually happy to see because he was debunking some of the misconceptions of OMPT.
Mhm.
And one important thing is it's hard to look into if it's not very specified. That's why
Mhm.
I was looking into uh, describing it as something that is being abused or
Mhm.
misused kind of
Mhm.
treatment. A lot of critics of manual therapy, they try to say, it's something like it's not effective. Patients will become dependent on it. As a matter of
Mhm.
fact, 8 different misbelief of or impression, wrong impression of OMPT are debunked and discussed thoroughly by this article, which I Chad Cook.
Mhm. Yeah, when I first read the title, the demonization of manual therapy,
Yeah.
I thought that it just clicked because I see a lot of physical therapists
Mhm.
that are bordering to hypercritical, being
Yeah.
hypercritical to the point that they are, yeah, demonizing
Mhm.
manual therapy, like it's like what they're saying is no one should use manual therapy, something like
Mhm.
that.
Yeah.
So I've also read some rebuttals about Chad Cook's article, especially from another well-known
Yeah.
physical therapist, Adam Meekins,
Mhm.
and what he said that it's not for him. It's not demonizing, but being critical of certain um, techniques or interventions that physical therapists do.
Mhm.
For you, why would you? How would you say that manual therapy is demonized or not, or how is it abused or misused?
Yeah. So for some individuals who may not be, like uh, acquainted to or uh, like thorough on how OMPT is being applied.
Mm-hmm,
Demonizing here means uh, portraying a specific or something to be wicked or something threatening or something that is worthy of contempt or something of blame. And I was looking at this earlier. It's something that you demean, it's something that you slander, or something that you discredit
mm-hmm,
because overall we don't really understand how is it done.
mm-hmm,
So OMPT has been one of the association that is that has a subgroup of the World Health Organization, also under the physiotherapy or the World Confederation of Physiotherapy or Physical Therapy, which is the IFOMT, the International Federation of Orthopedic Manipulative Physical Therapy. This is the international federation of OMPT bodies around the world that has a training that of the same standards.
mm-hmm,
And hence there is AYUMT in the US,
mm-hmm,
wherein we are fellows with. So IFOMT, we know for those who have been trained under a specific training, let's say a fellowship program in manual therapy, like what I was doing and some other colleagues, in UK, they have master's level. In Canada, in Australia, it OMPT is always defined as a specialized area in PT that uh, that manages neuromusculoskeletal condition based on clinical reasoning, using highly specific techniques like manual therapy and therapeutic exercises, using evidence-based, including the whole psychosocial realm of the person. So that is the definition of OMPT,
mm-hmm,
or manual therapy in particular, what the physical therapist should be doing as
mm-hmm,
far as those like specializing the area.
mm-hmm. So where do you think this hypercriticisms or this criticisms
Yeah,
to
that's
manual
criticism.
therapy
Mhm.
coming from? Is this coming from therapists that are not well versed with manual therapy, or is this coming from physical therapists who have studied under a certain school of thought of manual therapy that they think that it's not useful? So, in your view, where does uh this criticisms are coming from?
Honestly, I am not sure.
Mm-hmm,
I have my own like probably theories as well.
mm-hmm,
But I know these physios, these PTs or critics to manual therapy, they're great practitioners, they're great clinicians.
mm-hmm,
Um, but we know the fact that each of us has its own specialization,
right.
some are really, they don't like manual therapy because they work in acute, they just love acute care.
Mm-hmm,
Some just want to be in home health.
mm-hmm,
They don't even know any like specific, they don't want to work on that part of orthopedic manual physical therapy, and the
mm-hmm,
same as those who are devoted to the practice of manual therapy as well. So we have the passion of learning. As a
mm-hmm,
matter of fact, we have continuing educations. We do go to academy national conferences yearly for new
mm-hmm,
updates, and I think most of this are giving assumptions, and
mm-hmm,
and that's what the article. If you look at farther, there are 8 assumptions that
mm-hmm,
Chad Cook has pointed out
right.
that for those who are not keen into detail, sometimes we're just, or even like the public, they will say those assumptions are really easy to say.
Mm-hmm,
And then, but if we debunk each one based on evidence, actually there is an evidence that we can find that it is not true.
mm-hmm. One of the demonization that
Yeah.
Chad Cook mentioned
Mhm.
was this. this is interesting for me, is manual therapy techniques are based on outdated, inappropriate philosophies that were derived to support a guru's theories,
Yeah,
which he,
yeah,
Chad Cook, agreed.
yeah.
Um,
Mostly true, as I
Mostly
said.
true, right? So being, there's a lot of like certifications in manual therapy. There's a lot of school of thought on manual therapy. Each would have their own gurus or
Yeah.
promote proponents.
Mhm.
um is this where other physical therapists or physiotherapists that are not practicing manual therapists see where some manual therapists would have a sense of like um elitism, that they, since they undergone this certain certification, I'm better than you, or this is the only technique that's better on this type of condition or this patients. Is Would you think that's where it's coming from?
I think so,
Mm-hmm.
because there are specific theories that are specific to its specific founders, that they're really like proud to be trained under that specific like theory.
Right.
But we know that newer evidence, even like the concave convex rule, like the shoulder, it doesn't even
Right.
fit what's going on with what we learn in school.
Mm-hmm.
And then we have this chiropractic principles or theories too about subluxation. So
Mm-hmm.
there, for those who are, uh, let's say, let's say the point of view for public, and
Mm-hmm.
then for the public, they're
Mm-hmm.
given that kind of theories, which everyone just like believe, like, oh yeah, there's my spine actually sublux, that's why they realign it, or actually my shoulder when they glide it, it goes this way. Uh, Everyone will believe, but in modern like studies or research or evidence, actually it's actually not true.
Mm-hmm.
Hmm.
So organizations like AOMP or PAYOMP and the
Hmm.
IFOMPT
Uh-huh.
are some of the organizations that are trying to standardize, or at least give out evidences on
Hmm.
certain techniques.
Hmm.
Okay. So I believe like if a physical therapist would be going into manual physical therapy, they should be, joining fellowships or residencies to get a clearer picture.
That is one thing
Mm-hmm.
to definitely, that is one thing to advance knowledge,
Mm-hmm.
because that is in the level of hierarchy of training, I
Right.
always say. So let's say, for example, in medical education, after you graduate your doctorate, you go with your residency for the next specialization, and you do subspecialization to go
Mm-hmm.
to the next step. So I would agree with that. But in my training, um, in like even in a Payant, what
Uh,
we are trying to work is, there's this eclectic approach
uh-huh.
that each one should be aware of, and what are the flaws, and what are the the limitations of each. Because
Mm-hmm.
let's say, for example, MDT approaches, sometimes there are MDT approaches that really helpful for the spine,
Mm-hmm.
that are helpful for those nerve conditions that I use with my
Mm-hmm.
patients, but not all,
Mm-hmm.
because I have some other techniques that I can use better
Mm-hmm.
also to do. But for example, if you just use one approach and your mind is close to that, and you're
Mm-hmm.
not open to other approaches,
Mm-hmm.
that will be a different. I mean, that will be a problem. Like for
Mm-hmm.
example, manipulative therapy to the neck.
Uh-huh.
It as long my training, as long as you're able to cavitate the neck and you are ruling out red flags, you have the physiologic effect. You don't need to like, all right, you got to go up and then you go rotate, and then like very specific on kinematics at times.
Mm-hmm.
Sometimes we get lost into that, like trying to do a lot of, let's say, passive intervertebral testing, and in
Mm-hmm.
evidence it's not valid, because the reliability, the inter-rater is really low on that one. So that's why, if instead of like having, for example, instead of saying this C5, C6, C7 is really hypomobile,
Mm-hmm.
as if there is provocation in that area, and it provokes the familiar symptoms, then if it's hypo, then apply specific manual therapy techniques, and then the
Mm-hmm.
effect will be the same. there is the neurophysiologic effect, there's mechanical effect, and there's this like stimulation of the nervous system for pain management.
Mm-hmm. Because the debate and the discussion has been there for a long time:
Yeah.
exercise versus manual therapy, exercise plus manual therapy versus
Yeah.
exercise only. I mean, there's been that discussion going on, and now that taking a look at the value of each interventions that we are giving to patients, we
Mhm.
are now seeing that like most or passive modalities are something that we should use very rarely on
Yeah, right.
occasions, right?
Mhm.
Right. For manual therapy, is there a um, c- blanket statement where you can use manual therapy or you can't use manual therapy, or it depends?
Yes.
Mm-hmm.
So it definitely depends
Mm-hmm.
on, if it's indicated and contraindicated.
Mm-hmm.
So first thing is the procedure indicated or not.
Mm-hmm.
And of course, you're gonna rule out any red flags. For example, cervical spine. You have to know how to rule out those ligamentous instabilities, for instance, or let's say vertebrobacillar insufficiencies or issues, kind of thing. And then if it is indicated, then you do it. But going back again to what you're saying, on we go less with passive
Mm-hmm.
modalities. Newer evidence always point towards multimodal approaches in treating specific impairments or problems with patients.
Right.
And we know that the newest treatment classification system actually is not anymore, let's say, all we know is, for example, for the back, is we classify patient into direction preference, traction, or movement deficit, for example. But now they added actually the acuteness and the irritability of the patient. Because if the patient is highly irritable, the patient can fit into different classification wherein you actually start modulating the pain. And how will you modulate the pain? It could be modality, it could be manual therapy. You don't ask the patient to do like deadlift right away when the
Right
patient
away.
is highly
That's true.
irritable, right? And
Mm-hmm.
then slowly, when the pain is less irritable, then it could be a day after, it could be tomorrow that the next classification comes in. But there are overlapping classification systems by then that you can apply manual therapy plus those passive modality, but you should progress. The problem is if the treatment is not progressing, you just have passive modality for the next 5, 8, 10 visits. Passive modalities or manual therapy should be in conjunction with therapeutic exercise or
Mm-hmm.
any other approaches. So it's very important to look into how do you approach it and
Mm-hmm.
what kind of, based on your assessment with the patient, what's your goals.
Mm-hmm. So right at the bat, if you're gonna apply manual therapy, you should talk to the patient and mention that this is not going to be the standard of treatment, that this is going to be
Yeah,
just at the very start.
yeah. Mhm.
So how should physical therapists word those that treatments about manual therapy, so that one of the demonization here is patient dependency? So how
Yeah.
does a physical therapist word that to their patient?
Mhm. As a matter of fact, that is my practice. Like every day, I
Mm-hmm.
see chronic pain patients.
Mm-hmm.
That's primarily chronic spinal pain,
Mm-hmm.
neck or back.
Mm-hmm.
Um, Definitely, modalities and manual therapy has a role. But when you explain that to patient, after you do your initial evaluation, your objective examination, you discuss your findings, and
Mm-hmm.
then during discussion of the findings, what are the impairments, you have to educate the patient pertaining to, especially if it's chronic.
Mm-hmm.
Chronic pain is totally different from acute pain. And because during that time, even if it's chronic pain, because remember, chronic pain can be, there are good days and bad days,
Right.
good days and bad days. How about during that time when they come to the clinic, that was their bad day, but they have
Mm-hmm.
that pain for 15 years, for example. So during that time, because that's their bad day, the goal during that few days will be pain management, really.
Mm-hmm.
So I will tell the patient, you are really highly irritable right now as far as your tissues or pain level is concerned. So let's start with some pain modulating like approaches. So I'm gonna do just basic manual therapies for you today, and probably let's say electrical stimulation along with heat. But I'll let you know, we'll start with this for probably today, and then let's look at it tomorrow. If or the next visit, if your pain decreases, then we can slowly introduce. But this, what I'm doing right now, is not something that we're going to continue. We will progress with active involvement, because that's how the true changes will occur.
Mhm. That's right. I agree with that. But sometimes there are patients that, even though you tell them that passive, those modalities that you doing to them and the passive techniques that you're doing to them are just something that you are doing like at the beginning stage of the some patients do look for it. So
Yeah.
is it, how do we balance what the evidence says and what the patient wants and thinks that they need, because we're looking at the research, what's
Yeah.
that, evidence-based practice,
Evidence.
right? So there's also a part of the patient's
Yeah. Preference.
preference. So how do you balance that?
Yeah, so definitely you got to balance the triad of evidence,
Uh-huh.
especially if you practice and repeat what's
Uh,
proven in research
uh-huh.
or studies that are effective, and then what your clinical experience is pertaining to that, and
Mhm.
what's the patient preference too. So you take into consideration each of the factor there, not just imposing what you want, because the true change later on, because there is some, even there is a change even if it's not like specific to what the guideline is saying,
Mhm.
because you include the preference of the patient. But you've got, as I mentioned, balance and education, a lot of education,
Mhm.
because even in my case, I have patients that I have seen, or like for example, I see today that they had physical therapy a month ago. They just finished for the same issue, and they come back, and so that's the opportunity for you to educate this patient. Why are you coming back? Coming back? What's the difference? And then they wanna, like, I did. They cracked my back, and I want to continue doing that. So
Mhm.
now they have that misbelief,
Mhm.
misinformation.
Mhm.
It's time for you to probably change their thought about it, and at least educate them, because
Mhm.
for some of them don't actually understand what's going on. They just
Mhm.
feel that it is something that will help them. But the problem is dependency sometimes.
Mhm.
We're in, uh, if they can pay, it's okay. But of
Oh, yeah.
course, if you tell them to, what is right and what is wrong in the sense, I think some of them actually can get and understands, and then they start looking into like self-care management. Self-care management is very important for chronic pain conditions.
Mhm. Right. One of the demonization numbers or
Yeah.
statements that they said is that um, manual therapy doesn't have a long-term effect. As Chad Cook said,
Mm.
the long-term effect is coming from being able to move by the short-term effect of manual therapy. Anything to add on that?
Even if it's a short term, that's actually according to Cook, and what's also in research,
Mm-hmm.
short term effect is actually a good prognosticator,
Mm-hmm.
right? So I always tell that to my patients. For example, like application of dry needling, for example,
Mm-hmm.
like dry needling for low back pain, and then when they come back the following visit, I ask them, how was our last treatment? Has it helped you? It's like, yeah, it helped 2 days, but after that, it disappeared. But as a clinician, based on my experience, there are some individuals who does not even have a result at all. Like there's none. So I can already determine from 1 or 2 visits that this is a good prognosticator, that I can continue or discontinue. But if
Mm-hmm.
they have at least a short-term effect, I always tell them that's good. That's a good start, and
Mm-hmm.
we will continue. And then what you should be noticing. So you give them what to expect, what you will be noticing, because you have that short-term changes. Let's see, the next 2 or 3, that duration of effect should become a little bit longer. And then when it becomes, let's say, 2 or 3 days, then we can introduce some specific exercises that you can tolerate. So that's the best way to introduce new activities. New exercise will be a good progression from what you initially started. But that short term can also leads to a longer effect later on, because again, there are some that doesn't have any effect at all. And so for that, let's say after 2 visits and they don't have any effects, I tell them it seems like this doesn't work. So we will discontinue this. Let's try another approaches that will make a change.
Wow, good. What I got from what you're saying is that once you apply a certain technique, you should keep on reassessing the patient. If
That's
this
true.
works, then continue, then progress. If it doesn't work, you have to
You
discontinue
have to
it.
discontinue. Yeah.
Gotcha. So I guess that's where, physical therapists in general should learn from, would be like, look at the patient every visit, keep reassessing after each visit, keep reassessing and see where you can progress or discontinue some things.
Actually, that's a good habit for a clinician.
Mm-hmm.
To every visit, you have to reassess. You have to have at least something that you can objectively, not just subjectively, reassess next visit if there is any true change. If there is change, then that means I'll tell them, all right, we're in the right track. Let's continue this one, because otherwise, if not, I let them know too. Seems like it's not working, so we have to change the approach.
But there are certain times where you need to push through with a certain technique before observing a noticeable change, right? So again, how do you balance that when your patient said it's not working? How do you balance that? And you're telling them that let's keep doing that and see if that works. So how do you balance continuing versus discontinuing when something doesn't work with a patient?
I think one very important thing is it's more on clinicians' clinical decision making, really. So for me, in my practice, I give my maximum of a specific technique is like 3 times. Doesn't mean if it doesn't change, or if there are no detectable change, I will change it. Why? Because each time you apply, let's say the first and the second, our body has its own way to activate those, stimulating the neuroendorphin system, activating those substances that help with pain, physiologic or mechanical effect, let's say in manual therapy, to improve movement. So there should be an immediate effect, or even if it's just short term. If it's not, if there's zero at all, like in global rating of change, 0 or negative side, then that means that technique is not working at all.
Right. The reason why I thought about that, because recently I had a serious bout of pain after hiking. My sciatica flared up, and I was trying to treat myself since I knew that it was sciatica. So I did a lot of piriformis stretching, hamstring stretching, and stuff like that. Then it got worse and got worse, and I was like, I keep on doing the same thing, but it's not going away. So I tried positioning. I lay prone, but that seemed to make it worse. So I thought, should I stop laying prone or should I continue? Then I decided to continue, and the effect came in like 3 days after. I felt relieved. So I was like, if the patient told me that this laying in prone doesn't work, then my automatic reaction would be stop doing that.
Stop doing that.
But then since doing those for after 3 days, I was like, so there are times that there are techniques that you should try for more times before you can observe a certain change. I was like, that's a revelation for me.
And then the other thing too is going back to what I mentioned earlier. If it's really true acute, the tissue is still irritable during that time. And then as time goes by, after 72 hours, the pain, or any kind of inflammatory changes should decrease. So
Mm-hmm.
that's why there's a change. So during that time, well, we don't know if that was the true change,
Mm-hmm.
because of positioning, or
Mm-hmm.
it's just a
Subsided.
decrease of
Mm-hmm.
the inflammatory changes around the nerve.
Mm-hmm.
Like I had that experience too. I injured my back in the gym, and then I had I do my own like self mobilization exercises that I know for that kind of condition.
Mm-hmm.
Didn't change at all.
Mm-hmm.
In my mind, I'm not thinking about pain modulation like using modalities
Mm-hmm.
and
Mm-hmm.
breaths. So because I want to just do those exercises that focuses on, let's say, direction preference,
Right.
something like those.
Mm-hmm.
But actually, that's why the treatment classification has changed, adding the acuteness as well as the irritability of the condition. Because even if it's chronic and it's a new episode, you got to start with pain modulation, and
Mm-hmm.
then progress.
One thing, one problem I also remember with chronic pain patients is that you try to be more active with them, right?
Mhm.
And or you try to introduce self mobilizations
Mhm.
so that it's them, it's not
Yeah,
something they would not construe it as an external
yeah.
factor affecting them. It would be them doing
Mhm.
things by themselves. But there's like there are patients that are really really afraid to move, or to do those techniques by themselves, that they simply don't want to do it.
Yeah.
So as much as you want them to be more active in their own treatment,
Mhm.
they still want to rely on something passive.
Yeah. Chronic pain is totally a different game.
Uh-huh.
It's a different skill set compared to a managing acute musculoskeletal conditions.
Mm-hmm.
In chronic pain, it's a complex like uh, way of managing, because there are a lot of other systems involved. The psychosocial part is a big factor. That's why it's very important to assess even like the blue flags or the black flags, the yellow flags of these patients. And then sometimes in my practice, if the patient says their pain has been there for a period of months or years, I always measure their PCS score, the pain catastrophization score,
Mm-hmm.
because pain catastrophization is a huge factor for prognosis, particularly
Mm-hmm.
in neck. For instance, in the new practice guidelines, PCS is a big factor for poor prognosis, especially
Mm-hmm.
if they have high scores.
Mm-hmm.
So if they have that catastrophizing belief or
Mm-hmm.
attitude, the first thing you really have to do is educating them and letting them know on how to change, or your goal is to changing their belief on that
Mm-hmm.
false belief, or let's say fear avoidance,
Mm-hmm.
misophobia. That is actually, so the pain science, pain education now comes in, like
Mm-hmm.
your techniques on how to change these attitudes of these patients, like so psychological approaches, changing their thoughts, their belief, their fears about movement, because most
Mm-hmm.
of them they don't know, because most of the time, every time they move, it hurts. So and that's the thing. Self-care is very important, inculcating them on maintaining some specific activity, but letting them understand too that pain is not equal to harm in
Mm-hmm.
chronic cases, because all the acute changes has been gone. It's more of, it could be a peripheral sensitization or central sensitization. That's why there's this hyper algesia, or increase in pain perception in
Mm-hmm.
anywhere in the body. Like probably in your experience, you have this chronic back pain patient, but when you like just poke their side or their like here, it's like, oh, that's painful too. so
True. Yeah.
so you were like, oh no, what kind of condition is this? But
Mm-hmm.
it's actually more of hypersensitivity,
Mm-hmm.
because that's how the nervous system works.
Mm-hmm.
Time. So you've got to learn techniques, and it's very important for the PTs or practitioner to learn a different skill set specific for managing chronic pain patients.
Mm-hmm. That's interesting what you said. We're going off that, but it's okay. I'm
Yeah.
interested in what you're saying, because um, you're talking about chronic pain and catastrophizing. There, I had a patient that I tried to introduce. like pain science and stuff like that. And I had them read up, answer the PCS.
Mhm.
And what they told what he told you was like, um do you think that my pain is just in my mind, that I'm thinking about my thinking about the pain? It, I was like, how do you answer this? Like, it's not that you're thinking about it, it's probably just your body telling you that it's more pain than it
Mhm.
is. So
Mhm.
something like that. I was taken aback, but what he said, that us, or I am just thinking that it's all in his head.
Mhm. I know
So
that's true. Mhm.
mhm,
But for let's say for example, if I like encountered that in my patient, like do you think it's all in my mind? That's why
mhm,
I'm filling up this like because it's more of agreement, right? Like
mhm,
and that PCS.
right.
I will probably will say, well, how we interpret pain,
Uh-huh.
it's our brain that interprets it. So we're
Mhm,
thinking, or we are actually perceiving any kind of stimulus through our brain. So letting them know that pain is actually not just a process, let's say back pain, that
mhm,
you feel it in the back.
mhm,
Way we know that there is back pain because our brain processes it as pain.
mhm,
It's just when we process it, the part of the brain that processes it becomes more hypersensitive. That's
mhm,
what the result to that area will become more bombarded with high sensitivity. So sometimes those patients are, oh, I didn't know that it's actually that process. So
mhm,
yeah, I have some cases that I actually, even just during the first visit, it's all about education. And it's all about letting them understand. And it's okay if you don't. And
mhm,
then after let's say you perceive that they have changed their thought or they understand you because they agree. Oh,
mhm,
that's how it works. Then I can introduce like so. The first way really to address this is introducing a little bit of movement so that you can get back with the movement. So it's all about like pacing it, like
mhm,
visual imagery. There are different techniques on how to introduce so that they can feel better with the movements, and then a lot of motivation,
mhm,
for this kind of patients.
mhm. Right. So what you're saying is like, communicate with the patient first, teach them
Hmm.
about their
Yeah.
condition, their expectations and their goals.
Mhm.
Yeah. So we're kind of addressing what one of the demonization, which is the lack of skill and communication that
Yes.
some therapists would say that
Hmm.
manual therapy lacks.
Hmm.
But for, I mean, for those who are really like world versed for manual therapy, as you talk about the pain, the condition, and then um, let the patient understand stuff.
Hmm.
And I think where this demonization is coming from is from the wordings of some school of thoughts that releasing the fascia, or like
Yeah.
there is loosening, or
Yeah.
there
Yeah.
is, what do you call it, like the technique is repositioning.
Yeah. That's right.
So but if you're communicating um you know stuff that is the patient does understand, and that is true, then that is really helpful.
Yeah,
Mhm,
and the thing too, and that's it. It's the words that actually what kind of words the clinician is using. If
mhm,
they are using or the clinician is using words that are false,
mhm,
so like what you have mentioned. So
mhm,
I tend not to use those terms.
mhm,
When in manual therapy, I want to, or let's say for example, like just like like using my hand to stretch. I want to say this will release that tissue because I know that it will not,
mhm,
based on science, right?
mhm,
But I will let them know that this will stimulate the area to help, relaxes those muscle and
mhm,
then facilitate whatever you're doing, what kind of stretches you're doing. So there'll be like a connection that they can also understand. Not just
mhm,
purely scientific, but they can
mhm,
understand, but not giving them like false information that it will this will like elongate the fascia or everything, and then it will make a totally different structure after I do this.
Mm-hmm. So I'm not gonna enumerate all the
Right.
demonizations, but um a what should a good clinician, a good manual physical therapist or physical therapist in general have in terms of patient care, or you know so that somewhat we don't fall into those misunderstanding or abuse of techniques.
I think the one of the most important part is uh, make sure that everything that you do, you rationalize it.
Mm,
Is it something that is based on just your own principle, or are you balancing the triad of evidence as well?
mhm,
Because there are some individuals I know, because in a fact that for a fact that I had like one mentor one time, and all he is giving me is just his own opinion.
mhm,
Um, of course, that's good because that's his experience, but you're just using one like part of the triad, right? And
mhm,
then you're not presenting everything, kind of thing. So you have to make sure you balance. And then second is don't for me, I don't focus on one philosophy of learning. I have to
mm,
learn multi approaches, multi like principles, because otherwise if you are I remember one saying with my mentor one time: don't be don't be imprisoned by your own dogma, kind of thing, because you just believe in this dogmatic principle
mhm,
based on whoever you believe, and then you're a
mhm.
prisoner to that. You
Right.
have to be open to different kind of techniques. You don't want to you can critique in a sense, but personally, is this something good for this? But
Mhm,
on each principle, there's always a good for that specific, but
mhm,
not for this. So you
mhm,
balance this. That's why if you know these skills, you can choose which skills that fits the patient during that period of
mhm. So knowing the background and the rationale
time.
instead of just sticking to the technique
Mhm,
is best.
mhm.
Okay, for someone who is for a physical therapist who is thinking about going into manual therapy, um, where should they start?
So, for me, when when I decided to be an ortho specialist, my mind was really, I want to be a specialist in musculoskeletal conditions. So I did the specialization, the board,
Mhm,
the OCS, which gives me a good glimpse of the general musculoskeletal way of managing new
mhm,
evidence doing that. But after that one, I was like, I'm gonna focus on specific path in musculoskeletal treatment. So
mhm,
that's why the fellowship comes in, which is a subspecialty of. So do fellowship. Fellowship trainings is 1 year post residency, or now residency is not required as long as you have like certifications of,
wow.
uh, let's say you're a COMT or
Mhm,
COMPT. You can
mhm,
actually, even if you're not OCS, it gives you more um, way of learning critical thinking approaches. There are a lot of things that I've learned, as a matter of fact, in fellowship trainings, even prior to practicing the OMPT, or the technique as a whole. It gives me the way to think what's appropriate for the patient as well, and then
mhm.
give some good rationalization and apply evidence.
Right. And another way of learning more is through residency, as you mentioned, right?
Mhm.
Um, what is the value of going under through a residency program in trying to further your skill and your knowledge in the OMPT?
So for me, for new grads, for those
Mm-hmm,
who are already practicing in the field, and let's say they're already working for a year in ortho, that's their first time. You 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 don't need a residency, because sometimes when you go back to residency, you will cut your salary or what. But take that opportunity to have mentor to
mm-hmm,
teach you things. But the advantage of residency for those new grad who just finished their schooling is it continued for a whole year of mentorship.
Mm-hmm.
And mentorship is the guidance during that time with mentor who is already specializing in the field. So that when you are done with the residency program, you are ready to tackle those. Let's say, for example, you're resident in ortho or
Mm-hmm.
resident in neuro, you have the skill set to manage those group of patients. And then, of course, after that one, if you want to subspecialize into manual therapy, then you can. But definitely, it's a value. It's a good value for continued learning experiences and mentorship that you can actually have. Let's say, but I don't know. For some, there are some clinics actually that offers like mentorship, just
Mm-hmm.
informal mentorship as you're a new grad, you're joining a new clinic, and then the clinic offers mentorship, like one-on-one mentorship with the clinician there. That's also another way. But for clinicians, I would recommend choose a clinic for new grad or haven't started their practice in a specific field to find a mentor in that specific clinic to teach you those skills.
Right, right. So for those physical therapists in the Philippines who are listening to the podcast, residency is a 1 year program, right?
Yes, it's a year program.
Where a physical therapist would specialize on a certain area of their
Area.
choice, orthopedic, neurologic, or whatever.
Yeah.
Then they would take
Board
the
exam
board exam certification to be a clinical specialist on that
in
specialty.
that specialty.
Okay. Well, thank you very much, Yul, for sharing your thoughts and having me pick your brain on this article of Chad Cook on
Thank you so much for
demonization of manual
inviting me. I'm
therapy.
glad to be able to express and think and discuss about the matter.
But before I let you go, I have my last three questions. It's fill in the blank, no right or wrong answers. It's up to you. So, for one is um, success is dot dot dot.
Success is something that you know that you're contented with,
Mhm.
and that's for me success.
Right. Good. Good. Second question is, in order for us to elevate our profession, physical therapy, we should dot dot dot.
You should be an advocate. We should be an advocate to the profession. We
Mhm.
should be um, advocating it not only to our colleagues but also to the public.
Right. Great. And my last question, since the podcast is a complete meal of information and insights and stories, um, what are the three ingredients that are essential in your life? It can be a motto, a virtue, a value, a philosophy that you carry with you in your practice in your life. So, what are the three ingredients that make up Yul Hontilia?
One is be persistent,
Mm-hmm.
uh, advanced learning, and just be patient.
Mm-hmm. Learning and patient. Persistence, advanced learning, and patience. Good.
Yes.
All right. Again, thank you very much for your time. And I know Payo is going to have their
Yeah,
another
we have our
summit, right?
fifth international conference. I'm very happy about Payam's progression in the country.
Mhm.
As you know, it is the Association for Orthopedic Manual Physical Therapy, and we are actually in the process of being a member organization with the International Federation.
Right. And
Yeah.
Yul is gonna be one of the speakers, right? You're gonna be
Yes,
there. Mhm.
I'll be there.
All right. So watch out for that, guys. So again, Yul, thank you very much for being in the show.
Thank you, Johan.